Good evening, everyone. Welcome to Ask Your Mentor program session 4, organized by Tamil Nadu AOMSI. Today's topics are trauma of midface, upper face, and trauma of mandible, including soft tissue injuries. Mentors for this session are Dr. Chitra Chakravarti for midface and upper face, and Dr. Balaji for mandible and soft tissue injuries. The moderator for the session is Dr. Yogananda. Dr. Yogananda graduated from SRNC Chennai and completed his post-graduation from Annamala University. He has been mentored by none other than Professor Thangavellu. He completed his fellowship in implantology in 2009 and advanced implantology in 2011. Dr. Yogananda completed his MOMS and MFDS from Royal College of Surgeons, Glasgow, and MFDS from Royal College of Surgeons, Edinburgh and England. He completed his FDS in 2019 from Royal College of Surgeons, Glasgow. He is an examiner for Part 2 MFDS in the Indian subcontinent. He has published numerous papers in various national and international journals. Dr. Yogananda presently heads the Department of Craniofacial Surgery and Dentistry at Vellamal Medical College Hospital and Research Institute at Madurai, and is a senior consultant at Vellamal Specialty Hospital. His private practice is based at Anand Healthcare Center, Annanagar, and Anand Illumai Hospital, Madurai. We are pleased to have you with us, sir. May I now request Dr. Yogananda to introduce the mentors and start the program.
Thank you so much, Dr. Kalpa, and thank you, AOMSI Tamil Nadu, Pondicherry Chapter for having the third season of Ask Your Mentor program. And it's indeed a great privilege and pleasure to be moderating the session with two eminent speakers, Dr. Chitra Chakravarti, who would be mentoring on the upper face and middle third, and Dr. Balaji, who would be mentoring on the mandible fractures. So we will be beginning with the upper third and mid face, and let me introduce Dr. Chitra Chakravarti, who will be mentoring the session. She is the professor and head of the Department of Oral Maxillofacial Surgery at Navodaya Dental College and Hospital, Raichur, Karnataka. She is an alumnus of MCOTS Manipal. She has been an academician for the past 22 years, training undergraduate and postgraduate students. She specializes in maxillofacial trauma, orthognathic surgery, pathologies, TMJ, implant dentistry, and other areas of maxillofacial surgery. She has authored a textbook of oral and maxillofacial surgery, which is in its third edition now, and authored a handbook of dental instrument by Paras Medical Publishers. She is the director of Spark Center for Advanced Dentistry in Hyderabad, where she conducts clinical courses for dental students using newer technologies like 3D printing for surgical skill enhancement. With a special interest in 3D printing technology, for the past 10 years, she has fabricated innovative designs for better surgical practice. She also runs her own 3D printing lab with a team of engineers and fabricates 3D models, surgical guides, and patient-specific implants for maxillofacial surgical cases. She has numerous publications in national and international journals. She is also an international faculty for AO and has conducted lectures on various national and international platforms for the past few years. Welcome, Dr. Chitra, and right away we will start with the presentation.
Thank you, Dr. Yogananda. Sure. You can share the screen, please.
Yeah. And this is the initiative of AOMSI Tamil Nadu and Puducherry chapter. And yes, ma'am.
Okay, so the first question that was asked is when do we intervene for orbital floor as well as for medial wall fractures? So in this case, I would like to first start off a little bit. Could you go to the next slide, please? Yeah. So generally, when we talk about the internal orbital fractures, we talk about pure or impure blowout fractures. In this case, we generally, the internal structure, generally the orbital floor as well as the medial wall is what is fractured most commonly because they are the thinnest. You can go to the next slide, please. There were two important articles which I thought were very important, very good for postgraduates to understand. One was by Edward Ellis in 2012, and another one also which was given by Michael Bernstein I think these two articles have given a lot of gist of orbital trauma. Actually, I think the postgraduate should go through this. Could we go to the next slide, please? Yeah, so as I was describing pure and impure blowout fractures, pure is only when the orbital walls, which is also called a blowout, does not involve any of the orbital rims. And when we talk about impure, we talk about those in which the orbital rims are also involved. And usually it is associated with NOE, ZMC, as well as Lefort fractures. The next slide, please. So generally, there are three theories which explain this orbital floor fracture. There's the hydraulic theory, which is given by King in 1944, globe to wall contact, as well as a bone conduction theory. Although all the three theories are equally accepted, I think it's a combination of all the three theories which makes these kind of fractures possible. So the symptoms that we look for in these kind of fractures would be most commonly enophthalmos. Hypoesthesia is a very, very important indication actually, because the infraorbital nerve actually runs along the floor of the orbit, because of which there is a possibility that you must understand that the floor of the orbit could be fractured if there is hypoesthesia. Vertical diplopia is another important sign. Ecchymosis, which is commonly seen in most orbital fractures. Subcutaneous emphysema, usually seen with medial wall fractures, because you have the ethmoid sinus that is closely related to it. Epistaxis is again another of the symptoms that you would see in these type of cases. The next slide, please. So an important part is to go for the ocular examination. When you talk about the ocular examination, the previous slide. Yeah, so definitely check for the vision of the patient, check for the pupillary response to make sure that there's no optic neuropathy. Make sure we do a force duction test, because we want to make sure that the ocular motility is fine and there's no entrapment. In some cases, when you are thinking that there's possibility of an enophthalmos or an exophthalmos, definitely you can use an exophthalmometer and check for this as well. Important examination is to use a slit lamp to check for the globe injuries as well, like hyphema or iritis, or even dislocation of the lens, because this is an important factor for you to judge whether you should go about treatment, how you should go about your treatment also. So fundus examination also is a part of your examination process. A force duction test, as we all know, is performed with under sedation or under topical anesthesia, where we grasp the conjunctiva at the inferior rectus muscle, because this is what is entrapped in case of trapdoor type of fractures in the floor of the orbit. And you check for movement of the eye, and depending on the amount of range of motion, we are able to understand whether there is an entrapment or not. The next slide, please. Radiological examination forms a very, very important part of orbital trauma, because in most cases, the initial examination, as soon as the trauma is done, as soon after the trauma, when the patient presents to you, a CT scan is what will give you a very clear picture, more important than the clinical examination itself, because sometimes edema and things like that can mask your some of the symptoms that you would want to see in case of this type of a trauma. A CT, as I said, is a gold standard. You want to take 1 to 2 mm cuts to visualize the coronal, sagittal, as well as all the axial cuts. In a coronal cut, you'll be able to visualize soft tissue densities where you can see the prolapsed orbital fat or the muscle entrapment, sometimes even hematoma, which will give you a good indication whether the orbital floor has been fractured and how much of the defect is actually visible in that case. The next slide, please. So why do we treat, or in which cases? This is the main question actually. When should we treat and why should we treat? There are two main reasons for this. One is globe malposition, which will create enophthalmos or hypoophthalmos. There's a change in the orbital volume, usually the defects at the floor and the medial wall. Now that is the area where actually the maxillary antrum, there is a projection of the maxillary antrum that comes upwards in that area. We must remember that that particular projection is extremely important. If there is a fracture or a defect in that junction, usually the enophthalmos is very much prominent, and the patient will, you can actually visualize and see that the enophthalmos is seen in that particular patient. So according to studies, they say about 0.5 to 1 cc increase in the volume causes about 1 millimeter of enophthalmos. Now this is more to do theoretical actually, but in our case, we need to examine clinically to understand how much of enophthalmos is actually there, because this is one of the main reasons why you would want to treat a patient with an orbital floor fracture. So evaluate the size, evaluate the position, evaluate the extent of the defect, as well as the soft tissue herniation. In an acute stage, because of, like I told you, because of the hematoma, you may not be able to visualize or understand the amount of defect. Therefore, CT is more sensitive in these cases to evaluate an orbital floor defect. The next slide, please. So the next reason for the treatment of orbital floor defect would be to prevent or to treat a diplopia. So usually most patients have diplopia in the initial acute stages of trauma because of edema. Sometimes you might get a false evaluation of a diplopia in these patients. In those cases, a force duction test would be very important because a muscle entrapment has to be evaluated to understand that if there is a muscle entrapment of the inferior rectus, there is a possibility that the patient definitely has diplopia. So confirm this with the help of a CT as well to understand what is the size of the defect. Now, weigh the potential complications versus the benefit before you decide to jump into a treatment, because there are certain complications which could occur as a result of your treatment itself. Iatrogenic complications like asymmetrical palpebral fissure, intraorbital content injury if you're not careful, even sometimes infraorbital nerve injury, because of which you have to be very careful while treating infraorbital, orbital floor fractures.
Your audio is muted. Is your audio muted?
Sorry, are you able to hear me now?
Yeah.
Okay. So absolute indications where he says acute anophthalmos or a mechanical restriction, as we spoke about difficulty in ocular motility, is one of the most important things for treatment. A relative indication could be those conditions which are likely to cause an anophthalmos, like the size of the defect. Also, an important thing to remember is if it is behind the equator of the globe, that is right in the center of the globe, the defects that are present behind the equator of the globe are likely to cause anophthalmos more prominently than those that are present anterior to it. Or any reason that can cause a persistence of diplopia would be a relative indication for surgery. A relative contraindication definitely would be ocular injuries, like we spoke about iritis and hyphema or globe ruptures, or in those cases where the only seeing eye is fractured, you would probably think of not operating in these type of cases. The next slide, please. Yeah. So the timing of repair is divided into 3 types, whether you can have an immediate repair after about 2 weeks or so when the edema has subsided, or a delayed repair, which is much later on. So in which cases do you consider an immediate repair? In those cases where you have entrapped tissue causing functional limitation, as we already spoke about, in children especially, where something known as a white-eyed blowout. In these cases, what happens is they have an entrapment of the inferior rectus. It is only visible when the patient looks upwards in the superior gaze, but since the eye is completely white, there is no ecchymosis, there is no subconjunctival hematoma, you are not able to recognize this immediately. So definitely checking the gaze and checking for the force duction test is very important in children, because if you do not treat these injuries immediately, because of a trapdoor type of trauma, in these cases, there's a possibility of necrosis of the inferior rectus muscle, which is irreversible and then definitely has to be treated within 2 to 3 days of the trauma itself. A non-resolving ocular cardiac reflex, where the patient, especially seen in children once again, in case you have this type of a reflex where the patient presents with bradycardia every time they try to move their eye, sometimes even presents with syncope, this has to be recognized immediately because it's an ocular cardiac reflex. And this, if it is persistent, should be treated as soon as possible. Next slide, please. Where we already talked about the white-eyed blowout fracture. We can go on to the next slide. We are now talking about indications where the repair is done within 2 weeks. So actually, if you try to treat orbital floor injury with so much of edema, because there's so much of subconjunctival ecchymosis, there's even circumorbital ecchymosis and edema. If you try to treat it when the edema is present, sometimes you're not able to access the floor completely, and you're not able to give a very clean incision as well in that edematous situation. So in these cases, if there is no restriction of ocular motility, but there is a CT evidence of a defect, now these cases can be treated after a period of about 2 weeks when the edema settles down. This is mostly done in adult orbital fractures, because in these cases, there is no trapdoor-like injury. It is more of an entrapment. That a positive force duction test is there, in some cases even present with diplopia. So wait for the edema to subside, get a good access, lesser chances of globe injury because you're not putting so much pressure on the globe because of the edema. And like I told you, usually those defects that are 2 into 2 centimeter large, or those defects which are larger than 50% of the wall behind the equator of the globe, are most likely to cause anophthalmos. So these cases would definitely be candidates for repair within 2 weeks of the trauma. The next slide, please. In some cases, where you might want to observe and possibly do a later intervention in these cases. The patient has a good ocular motility, very minimal diplopia. There's a very minimal defect in the CT. Only if the patient presents with symptoms later on, these can be intervened. Otherwise, you don't need to. Next slide, please. So this is just a clinical case given by Dr. Yogananda, actually. A beautiful case where you can see that it is an impure blowout fracture. There's orbital floor injury can be seen very clearly. There is an intraorbital rim injury as well. The next slide, please. The CT shows a defect. You can see a beautiful defect that is visible over there. Definitely requires repair because there is possibility of herniation of the contents into the maxillary antrum and a possibility of entrapment as well. So in these cases, it is important to first get the orbital rims into perfect position. So as you can see, we have opened the frontozygomatic area. You have to first get the orbital rims into position. Only then you attempt the orbital floor reconstruction. So the zygomatic complex has been repaired completely. They have gone through a transconjunctival incision, which is a very beautiful incision because it gives you access to the floor of the orbit as well as the orbital rims with minimal scarring on the face. This will, with no scarring on the face actually. So transconjunctival incision, in this case, they have used an orbital mesh, a titanium mesh has been used, which also fixes the intraorbital rim as well as the orbital floor. So, and this is the type of repair that you would do for a orbital floor fracture. So let's go on to medial wall fractures, very similar to an orbital floor injury, but in these cases usually seen as a result of blunt injury to the orbit. In these cases, usually the entrapment or the enophthalmos in these cases is very little and not very easily made out in clinical examination. The theories are the same, the buckling theory, the hydraulic theory, as we already discussed in the orbital floor fracture as well. What you would see in this case would sometimes be air entrapment into the soft tissue because of the ethmoid sinuses, especially if the patient has a blood clot in the nose and they're trying to blow it out forcefully. In those cases, there's a chances of air emphysema entering under the skin. Next slide, please. So why would you want to go or do a surgical intervention in medial wall fractures? As we already said, the junction between the medial wall and the orbital floor is a very important aspect where there is an elevation or a convexity of bone that is present. That is one area that we must look for in a CT scan, because if there's a trauma to that area, definitely we need to reconstruct the medial wall as well. If there is a diplopia, a similar indication as we saw in the floor, if there's a diplopia, clinically significant enophthalmos where we have a positive force duction test, a significant change in the position of the globe, or if there is a compression to the optic canal as we see clinically, in those cases, definitely you would want to intervene and repair the medial wall as well. So if there is an entrapment or an evidence of the entrapment of the medial rectus muscle, we can also check with the force duction test. The patient sometimes even presents with bradycardia, as we spoke about the oculocardiac reflex, while they're attempting to move the eye. This is also an important indication for treatment or in surgical intervention of the medial wall as well. Now, patients with normal motility, regardless of the size of the fracture, if you feel that later on there's a possibility of developing an enophthalmos, in these cases also you would want to surgically intervene. Now, can we go to the next slide, please? Oh, sorry, I thought there was something else there. Okay, right. Okay, so medial wall can also be approached. Sometimes we do a repair of the orbital floor along with the medial wall. We can use titanium meshes and reconstruct both of them. Your limiting factors would be the anterior ethmoidal and the posterior ethmoidal arteries. In this case, you would want to only repair up to that area and try to close the defect as far as possible. The next slide, please. Can we go on to the next question?
Yeah, with that, we complete the discussion on orbital floor and medial wall fracture. So the indications, the timing, and the choice of material and technique, and that's what you need to remember in your orbital floor and medial wall fracture. So the next question is, how is sequencing of pediatric panfacial fracture different from that in adults? Ma'am?
Okay. First we need to remember that pediatric patients are treated slightly differently from adult patients, not due to the trauma itself, but even due to their their general body condition as well, which we need to remember. So when we're talking about panfacial fractures, we are talking about facial fractures which involve the upper, middle third, as well as the lower third of the face. We'll go on to the next slide. So I want to show you some things which are slightly different in a pediatric fracture compared to an adult fracture. Usually these fractures are very poorly understood, often incompletely treated, as you very correctly stated here, because the child generally does not tend to show up with the symptoms, or they're not able to express, and sometimes many of the fractures are neglected, especially the NOE fractures are not usually seen or clinically when you look at a patient in a pediatric condition. Next slide, please. Okay, two articles which I thought were very, very descriptive, especially the second one, which is given by Braun et al., where they talk about differences in management of pediatric facial trauma. I think all postgraduates must read these articles as well. Please go to the next slide. Usually pediatric fractures are rare. Only 12% of trauma is seen in this type of midfacial pediatric fractures. Mostly these type of fractures are soft tissue or dentoalveolar trauma is usually seen. There is lesser displacement of these type of fractures because there's a lot of fat pad that cushions these type of fractures. Usually in patients, pediatric patients, like I was telling you, these patients have got a higher metabolic rate, the surface to volume ratio or their oxygen demand, also the low blood volume, makes them very highly susceptible to hemodynamic instability. Now, this is a very important point to remember, because when we see the patient in the trauma center, it is important to first stabilize all these before you jump into starting with your management of the pediatric trauma. There is a possibility of hypotension, hypoxia, as well as hypothermia post-trauma. All these need to be addressed first before we go on to the actual management of the trauma itself. So there's a possibility in these kind of cases with trapdoor fractures, as we looked at in the orbital floor injuries, the white eye blowout, as we already discussed, possibility of bradycardia or the oculocardiac reflex, which we also discussed. Most of the cases, the NOE fractures are usually missed because of the edema in pediatric fractures. The next slide, please. This is just a little bit of data on pediatric trauma, actually, where usually the mandible is most commonly injured and the zygomatic arch is the least commonly injured in these type of cases. The mechanism of injury usually between the age 0 to 5 is because of just daily activities. Between 6 to 11, usually motor vehicle accidents, bicycle riding, or 12 to 18 years is usually where you see the interpersonal violence or the sports related injuries. Can we go to the next slide, please? Okay, so what is different between an adult and a pediatric trauma? Usually the type of protective features that are present anatomically in a pediatric skull is very different from an adult skull. So this is something that we need to remember, because based on this protective feature, the type of injury that we see or the outcome that you see of the trauma would be seen over here. And based on this type of anatomical difference in the pediatric and adult, your type of treatment also, or your modification in the treatment, is also done accordingly. So the protective features that I would like to discuss is first that there is an increased cranium to face ratio in a child. Now, because of this, they are more likely to sustain skull injuries when compared to maxillofacial trauma as such. That is the reason why you see lesser amount of maxillofacial pediatric trauma. There is an increased flexibility of their bones. Okay, because of this high elasticity of their bones, you would most likely see green stick fractures very commonly when compared to actual trauma that you see in case of adult fractures. There's an increased tooth to bone ratio, which again increases the stability as well as the flexibility of the bone. And because of the lack of pneumatization of the sinuses, there is a reduced facial projection, which also protects the child from trauma. So these are the protective features that we need to remember. What are the modifications you do in this type of pediatric facial trauma is, you would want to, because the patient has, the bones in a pediatric patient has got a very high osteogenic potential. If you want to do a surgical intervention, you must do it within 4 days. Otherwise, it tends to form a callus very rapidly, which becomes difficult to treat. Now, just a point of mandibular trauma. In case of ankylosis, you would want to apply the maxillomandibular fixation only for a period of 7 to 14 days. Now, because it is a pediatric patient, you want to do surgical interventions only in those cases it is indicated when, or an open reduction is indicated only when the fracture is very displaced, because there is a risk of scar tissue and because of which there is a growth disturbance is possible. Especially in midfacial fractures, if we do a lot of skin incisions and open up the trauma completely, in those cases, once it heals because of the fibrosis, there is a very high chance of midfacial hypoplasia in these type of patients, which might need to be addressed later on when the patient grows older. Now, the management of non-displaced fractures can usually be done with only liquid diet or soft diet, analgesics. These type of things will probably avoid the growth disturbance completely. You can go to the next slide, please. So what do we do in different types of fractures that you would see in the midface generally? If it is a frontal bone fracture in a pediatric patient, you want to just restore the contour. If there is a CSF leak, you would want to manage it. If it is not displaced, then no intervention at all. Only if it is displaced with an injury to the duct, in those cases, you want to do a surgical intervention. Otherwise, you would leave it alone in case of a frontal bone fracture. In orbital fractures, usually try to go as conservative as possible. Surgery is indicated only if the defect is very large, if there is a traumatic optic neuropathy, and there is an entrapment, as we spoke about, a white-eyed blowout. In those cases also, you would probably want to do a transconjunctival incision with a lateral canthotomy. This is preferred because the scarring is much less in these type of cases. Midface and zygomatic complex fractures, the goals are same as the adult. You want to replace the entire vertical and horizontal dimensions. If it is a minimally displaced fracture, a green stick, or a no displacement fracture, do a complete conservative management. If it is only displaced, comminuted, only in those cases you might want to go for an open reduction, or sometimes even do an intermaxillary fixation. Now, because the pediatric teeth are so small, you cannot obviously place arch bars. We generally go with orthodontic brackets, or some people come up with very innovative methods of going about in intermaxillary fixation. So intraoral approaches wherever possible if you want to do an open reduction. Nasal and NOE fractures, as far as possible, closed reduction. Sometimes in NOE fractures, because the bones get so fragmented, you might want to do a transnasal wiring instead of going for a plating in these cases, because it is almost impossible to put a plate in these type of bones. Next slide, please. Another case here showing a pediatric fracture, midface fracture. You can see a frontal sinus, NOE, as well as a complete Lefort fracture as well in this particular case, along with a panfacial fracture where the mandible is also fractured. The next slide, please. So in these cases, in this particular case, they have gone for a bicoronal approach where the entire frontal sinus as well as supraorbital rims, everything can be approached with this bicoronal approach. The next slide, please. This is a pediatric trauma. Again, you can see there's an existing laceration on the face, and the entire trauma has been approached through this laceration itself. In pediatric trauma, there is a dispute on whether you want to use titanium plates or whether you want to use bioresorbable plates. Now, that is another point of discussion completely. Bioresorbable probably because it does not hamper the growth and it would resorb and allow the bones to grow normally. Okay, so can we go on to the next slide again? So this is the post-operative, the lateral as well as the PNS. You can see how the bones have been fixed with titanium plates completely.
Yeah, that brings us to the end on discussion of the sequencing of panfacial fractures in pediatric fractures. I mean, like the pediatric population, the maxillofacial injury management is like totally different as compared to your managing fractures in the adult population. So you need to have absolute indications when to intervene and for how long to intervene, the method of fixation, everything has to be taken into consideration before you can address a pediatric maxillofacial injury, panfacial injury. But the sequencing remains more or less the same, whether it is like bottom up or cephalic caudal or from the outer table to inner table. But what you need to remember is like the central core is, as Madam was telling, the NOE complex needs to be given due importance, because that gives the projection and the hampers with growth if not addressed properly at an early point of time. So that brings us to the discussion on sequencing and panfacial fractures for pediatric patients. The next question is, what are the different treatment options for comminuted midface fractures? Ma'am?
Okay. So the different treatment options for comminuted midface fractures. Now we should understand that the midface, as we are talking about, has got two stable things that we need to think about. Whenever we talk about comminuted fractures, we are trying to fix a shattered bone to stable bone, whether above and below. So when you have a comminuted fracture of the midface, the cranium or the cranial base forms your superior stable bone, and the dental occlusion or the mandible forms the inferior bone, which is stable. So in this case, we know that the midface generally does not fracture as a single bone. It generally has comminuted fractures because each of those bones are so closely internated with each other. There is a possibility that when there is a fracture, this entire midface generally tends to shatter or crumble into smaller pieces. Now, cosmetically as well as functionally, this is a very important part of the face because this gives your projection. And our idea of treating a mid-face, whether comminuted or regular mid-face fractures, would be to address the buttresses. You want to regain the vertical height, the width, as well as the projection of the face completely when you're trying to treat mid-face fractures. The next slide, please. So the sequence of treatment, although there are so many different types of treatments, as Dr. Yogananda just mentioned, whether you want to go from cephalic to caudal or caudal to cephalics or from outer to inner or inner to outer, each of those things can be debated upon, and each of them have their advantages or disadvantages. But in general, when we attempt to restore a mid-face, we would first want to get the dental occlusion with maxillomandibular fixation, so that once the dental occlusion is in place, the rest of it can be treated according to that. Now, you want to get the maxillomandibular fixation done prior to attaching the segments of the mid-face to this. Now, maxillomandibular fixation generally restores the position of the base of the maxilla, and it allows us to reconstruct both inferiorly as well as superiorly. Now, if the mandible is also fractured, you want to fix the mandible first and then go ahead and do the maxillomandibular fixation and then start with the midfacial trauma. The next slide, please.
Change. I have changed.
Sorry. The fixation, now what is the objective? Like I told you, the objective is to get a good nasal projection, the anterior-posterior projection, which is very important. If you go to the next slide, actually the buttresses are seen in that. Yeah, so these are the vertical buttresses as we speak about, the nasomaxillary buttress and the zygomaticomaxillary buttresses. Now, these are the areas that you want to fix. Once you get your stable base, which is your mandible and the occlusion in position, the next thing would be to try to bring these bones into that particular position to reconstruct the vertical buttresses. Now, once you have reconstructed the vertical buttresses, you should start thinking about the horizontal buttresses of the midface. Now, this is the supraorbital rims, you have the infraorbital rims, and you have the zygomatic arches on both sides, and you have the maxillary alveolus. Now, all these things have to come into place. Now, once all this has come into place, the next thing you would want to address would be the nasal bones and the nasoorbital NOE fracture. Now, that would be the next step. Can we go to the next slide, please? As you can see in this particular clinical situation, you can see a very, very displaced zygomatic complex fracture as well as a maxillary fracture where the entire arch has collapsed completely medially. In this case, you can see how the occlusion has been completely deranged, and this is a part of a very complicated midface fracture where addressing the occlusion is one of the most important parts in this particular type of trauma. Can we see the next slide, please? We can see that they have first put the patient into maxillomandibular fixation. They have brought the occlusion back into normal. Luckily for us, the mandible was stable in this particular case. So the maxillomandibular fixation has brought the maxillary dentoalveolar segment into position. Once that has come into position, you can see how the vertical buttresses have been aligned. The nasomaxillary as well as the zygomatically maxillary buttresses have been aligned. And we can check the occlusion on both sides, which is completely stable. Now, this gives us the entire projection of the midface. As we all know, once the midface has been fractured, it tends to go downwards and backwards. It is important for us to bring this out, bring it into position, get the occlusion, and then fix the buttresses so we are able to get our vertical projection of the maxilla. Next slide, please. So this is sorry, is this the same case again?
No, it's a different case, ma'am.
Yes, okay. Yeah.
Central middle, the
Central midface fracture.
And the maxillas bilateral.
Yes. So this is the NOE as well as the maxilla. This is a central midface fracture, different from what we saw in the previous case. Can we see the next slide, please? In this case, bicoronal approach again has been used. The frontal sinus has been fixed with large reconstruction plates. As we can see, these mini plates have been fixed to completely bridge the entire frontal sinus area because the anterior table of the frontal sinus has completely been shattered in this case. The next slide. It has also been attached with mini plates to the nasal bone. This is the fixation intraorally. It has been approached where the buttresses have been addressed on both sides. Long mini plates have been used in this case also to reconstruct the vertical maxillary buttresses in both the sides. So this is again the isolated central middle third fracture, as we saw. This is the same patient as we are talking about over here.
No, it's another case. No? It's this bilateral NOE complex with the anterior cranial fossa injury.
Anterior cranial fossa injury. Okay,
Yeah.
right. Okay. Okay. Again, this is an open sky approach. We have directly gone through. Was there a laceration? We've gone through an existing laceration in this case. So this is a very good approach to the frontal sinus as well as the NOE complex in this case. You can see how the bone has been shattered, has been reconstructed completely, and plates have been used, mini plates have been used to fix the fracture, to bridge the entire gap completely. So the anterior table has been reconstructed. This is a case of a unilateral lateral middle third injury where there's a right zygomatic complex fracture and a comminuted arch fracture. In this case, we can see, I think they're using an fiber optic intubation in this patient because in many of these cases, usually intubation becomes very difficult. In this case, a hemicoronal approach has been used because if you look at the arch in the previous slide, you can see how the arch is completely shattered. It's impossible to do a closed reduction in this particular case. You have to do an open reduction to completely get a projection, that is the lateral projection of the arch. So the arch has been exposed with the hemicoronal along with the zygomatic bone also has been exposed with the same approach. And the arch has been fixed with a long plate, which has been extending all the way from the posterior to the anterior up to the zygomatic bone. There's a post-operative X-ray. You can see a beautiful projection of the lateral aspect of the zygomatic arch.
Yeah, that brings us to the discussion on comminuted midface fractures. Whenever you're talking about midface, you think both in terms of central middle third and the lateral middle third fractures. And it is always a combination of all the bones, your frontonasal, frontoorbital ethmoidal complex, or your nasal bones, or your bilateral maxilla, your zygoma, your arch fractures. It can be a combination of any of those fractures. So whenever you have such an injury, a comminuted injury, as ma'am was telling, always remember you have a stable cranial base, you have a stable occlusal base, you need to get your fixation into position, your MMF into position. And once this base is stabilized, then you reconstitute the entire middle third. So the next question is indications for using stride plate and L plate for fracture fixation. Ma'am?
Yeah, so not much material on this particular question actually, but what is the idea of fixation? Or what do we want to do? We want to restore, we want to reduce the fracture, we want to fix, and we want to restore the normal anatomy in any kind of trauma. Now, what type of plate we use, again, depends on personal choice to some extent, depends on the type of fracture also to some extent, how much of stable bone you have, and how you are able to fix it in the clinical situation itself. So the idea is only very little or minimal handling or very careful handling of the soft tissue, minimal reflection as far as possible, and preserve the vascularity of the soft tissue as well as the soft tissue of the bone also. So in these particular, there was one article that I found, if you can go to the next slide, please, is the effect of using different methods of plate fixation in maxillary Le Fort 1 fractures. They have used different types of plate, straight plate, L plate, all the different varieties, and they've done actually a finite element analysis study in this particular case, where they have shown actually that the L plate, use of 4 L plates in case of a Le Fort 1 fracture, where we reconstruct the nasomaxillary as well as zygomatic buttress. In this case, actually the L plates are supposed to give the maximum stability. Although there is not much difference really between an L plate or a straight plate, I think the idea is to reconstruct, the idea is to preserve the blood supply, and whatever works in that particular area, we should be able to place. I don't think there's a particular preference for any one type of plate. Dr. Yogananda, any other information on that?
As we were telling, it is a choice of personal choice, what you want to use. But one thing that we can take into consideration is in trauma, I mean, like it is much convenient to use straight plates when you're reconstituting. Yes. But when you're doing orthognathic surgery, I think you may have an option to use various designs, especially in your midface, your genium. You have site-specific implants, which gives better stability to the osteotomized segments. But in trauma, it depends on the type individually. I think it varies case to case. When you open up and we see the fracture, whatever offers the best stability should be the plate of choice, the design of the plate of choice. But we are mostly into use of mini plating systems, semi-rigid fixation. So I think unless and until you're going for something like a reconstruction plate or where it is already size and side decided, right side or left side, all that can come into play. But otherwise, I think it is really not much an issue on the type of plating system or the design of the plating system that you go ahead and use. That brings us to the discussion on this question. Next question, what are the indications for surgical intervention and treatment of frontal sinus fractures? It's again an overlapping question, what we had in continuation with your orbital and your midface fractures, but we'll just take it quickly.
Okay, can we go to the next slide, please?
Yeah.
Okay, so there are 5 important things. I think we'll go to the next slide also. Okay, so the 5 important parameters, because I'm just running through this because we've almost addressed most of it actually. 5 anatomical parameters that we need to look into when we're talking about frontal sinus fractures, whether the anterior table is fractured, whether the posterior table is fractured, whether there's a fracture of the nasofrontal recess, whether there's a dural tear along with CSF leak, or whether there's a fracture displacement or a comminution. Now, these are the 5 things that you need to look into. Can we go to the next slide, please? I just found a beautiful algorithm actually that was given in CMTRO 2009. I'll just describe this very briefly. I think it addresses the entire thing. So if there is a nasofrontal recess injury alone, in those cases, you can say whether it is mild or moderate to severe. If it is mild, then you just observe and you can do an endoscopic surgery if it is necessary. If it is moderate to severe, only then you will go ahead with obliterating the frontal sinus. If the nasofrontal recess injury is associated with an anterior or a posterior table fracture, then there is different types of managements that you look into. If it is only an anterior table fracture, if the anterior wall is displaced, yes. In those cases, if it is communicated, in those cases, whether there is not much comminution, in those cases, you will just go for an ORIF in those, if it is not comminuted as much. If it is severe comminuted fractures, in those cases, you will go either possibility of a bone graft. If it is not possible, only then you will obliterate the frontal sinus completely. If there is no anterior wall, displacement, then in that case, you will only observe and you will not want to do any intervention at all. Now, when it includes a posterior table fracture, just check whether the posterior wall is displaced completely. If yes, more than one table width completely if it is displaced. If there is CSF leak, yes, in those cases you will do a cranialization versus obliteration. You have to decide what you want to go for. In obliteration, many people discuss about different materials that are used for obliteration. Dermis fat is something that has been used most commonly for obliteration of the frontal sinus. If there is no CSF leak, but a severe comminution is present, if it is moderate to severe, again, you would want to debate on cranialization versus obliteration. Or if it is a mild comminution, you want to just obliterate the sinus. If there is a CSF leak, then you will only observe. If it is persistent, only then you will treat. If it is not there, then you will just observe and it just resolves on its own. So I think this is an important algorithm. It basically sums up the entire frontal sinus injuries as such. So this is a clinical case where you can see a completely comminuted anterior table fracture in this particular case, along with the midfacial trauma as well, bilateral Lefort 2 fracture with an NOE, I think, as far as I can see from this CT scan. Yeah.
NOE and anterior cranial fossa.
Anterior cranial fossa as well. Okay, so you can see in this case, bicoronal approach, obviously, and the entire anterior table has been reconstructed with mesh. Am I correct, Dr. Yogananda? Is that?
Yeah, that's right. It was too fragmented to replace it. Once the ACF repair was done, facial at a place, and then they have plugged the frontal sinus, obliterated the frontal sinus. We couldn't get back the residual bone back there. So we went in for a mesh reconstruction to give the.
I think the residual bone was too shattered to be placed again. Yeah.
And the rest of the midface fracture completed routinely.
Yeah.
This was another case. And again, fat and facial lattice.
Fat has been used in this case for obliteration of the frontal sinus.
Yeah, yes, it was another case, frontal bone fracture. I think that gives us a rough idea about the entire upper third face. You've seen the orbit, NOE, middle third, and the frontal bone. I think that completes the entire upper third face, all the kind of injuries. So we've looked at the various indications. We've looked at the timing of repair. We've looked into the possible scenarios in which the upper middle third face can get fractured and the types of fracture that can frequently occur both in the adult and the pediatric age group, and the choice of reconstruction materials and the types of plates that you need to go about using, and the complications. That gives us a brief gist. We'll quickly move on to the next question. A few questions that were put up by the postgraduates. What is Muller's muscle?
Okay, so Muller's muscle, also known as the superior tarsal muscle. Now, this is actually a very important smooth muscle, okay, which receives its innervation from the sympathetic nervous system. It has got very thin fibers of the smooth muscle. It is attached below the levator palpebrae superioris. Now, damage to this muscle, as such, damage to this particular muscle or any of the nerves that supply this particular muscle can cause ptosis, which is called, which we see as Horner syndrome actually, or damage to the cervical sympathetic chain also. So it is very important for us to address this, especially in upper eyelid injuries or in cases of upper eyelid approaches to the orbit. So I think there's nothing much to really discuss about the Muller's muscle. Maybe we can move on to the next question probably. Anything else you want to add, Dr. Yogananda, to this?
No, it was just to give the postgraduates an understanding what it is. So as you told, it's a thin, smooth muscle located in the upper eyelid. Injury to it predominantly causes ptosis. So you need to be very careful when addressing it and managing it. What is Marcus-Gunn pupil?
So Marcus-Gunn pupil, it's an aberrant pupillary response. So normally when we shine the light in one eye, we see a direct reflex, and we also see a consensual reflex in the other eye where there is a pupillary constriction. And the moment you take the light away, the pupil again dilates or comes back to its normal size. Now, in case of a Marcus-Gunn pupil, you see a constant, because this pathway, if there's an injury, now in our case, we are more concerned of, it can be seen in so many different conditions, but in our particular case, we are concerned about trauma. So if there is an optic nerve injury, we generally see a Marcus-Gunn pupil where you see a dilatation in response to the light that is applied to the eye. So the Marcus-Gunn pupil will remain dilated despite exposure to bright light. I think this diagram is very, very explanatory actually. When there is no light, when there is a consensual right reflex, and you can see the dilated pupil in the third figure when you have put a consensual reflex for this. When you're shining the torch in the opposite eye, you can still see a dilated pupil in the adjacent eye. So this is very important, especially to diagnose optic nerve injuries in case of midfacial trauma.
Yeah, it sums it up. It is something that you do during the primary survey in the emergency room to, as you assess the neurological status of the patient, the ophthalmic status. It is one of the, from medical legal point also, it is very important that you identify this ocular injury and optic nerve injury at the triage itself when the patient is wheeled into the casualty, because identifying it later, once you've done all the fixation wonderfully, and then if you come back with there is some difficulty with vision, and then it becomes really a challenge. So this consensual eye reflex, RAPD, is something that Marcus-Gunn pupil is something that you identify early in the casualty. Next question, I think we're coming to the last question of the session. Different materials used for orbital floor reconstruction. We've talked extensively on orbital floor. We'll just quickly talk about the choice of materials available.
Yeah. So what should we consider when you're talking about the type of material to use? The size of the defect, the mechanical properties of the material, the thickness of the material, or whether the material can take the load of the entire orbital content on that particular material. Now, this is important to consider. There's a huge flow chart that is there. I'm not going through this whole thing. I'm sure Dr. Yogananda will throw me out right now if I start with this. So this is very elaborate though. But I think postgraduates should probably go through this because it gives a complete, rundown on the different types of materials and how you can consider what to choose. So like I said, there are 4 things that you need to consider: the size of the defect, the site of the defect, what type of material you want to use, especially the mechanical properties. Now, if you are using, let's say, a resorbable type of material, you must remember that the resorption should not be so rapid that it does not allow the formation of the bone in that particular area. So the bone formation as well as the resorption, the time should match each other. The different materials that are used, can we go to the next slide? Yeah. So they're basically classified into 3 types. You have autologous, allogenic, and alloplastic materials. Most commonly in bone or cartilage, fascia lata, or periosteum is also used. Bone can be taken from the cranium. There are even case reports of using a coronoid process for reconstruction of the orbital floor. You have different types of bone that you can take, even from the mandible. Also, people have taken bone for reconstruction. The cadaverial bone is very good in this particular case because the shape of the bone is such that it actually allows for a good reconstruction without much shaping in case of autologous materials, because that is one of the problems. You have an additional donor site and you also need to shape it to bring it to that particular contour that you are looking for. So cartilage can be taken either from the ear also. You can take ear cartilage if it's a small defect. Again, the thickness of that particular cartilage should be judged before you go for this type of material. Iogenic material, you can have lyophilized dura, cartilage, fascia lata, or even bovine bone can be used. So many different varieties of alloplastic materials. Most commonly used is titanium mesh, as we most commonly use. Nowadays, even PEEK is also being used as orbital floor reconstructive materials. You can have polyglycolic acid, polydiaxonone, all types of resorbable materials that you can use. Also, patient-specific implants are being used nowadays as part of orbital floor reconstruction as well.
Yeah, that gives us, just for the sake of completion, now with the advent of virtual planning, mirroring, and patient-specific implants, I think that is gaining more momentum with orbital reconstruction, where you can be, where you have the leverage to precisely reconstitute the defect. But otherwise, from a general standpoint, the choice of material broadly depends on the size of the defect, site of the defect, and the convenience with which the operator can handle those materials effectively and see to that it stays in position once placed in the patient. So that brings us to the discussion of the upper midface. Thank you, Dr. Chitra ma'am, for throwing us such a wonderful understanding about all the questions that were put across by the postgraduates in a very precise and concise manner, and in a manner in which they could understand and relate to. Thank you, ma'am. I think we will quickly move on to the next topic. Dr. Kalpa, we will end this presentation and we will start the mandible. I'm just about to screen share. Dr. Balaji?
Sure, sir.
Yeah. Dr. Balaji, you're there?
Yeah, I'm there. Major portion of the burger is eaten. Now we'll go through fast.
Yes, sir. Yes, sir.
It was a nice, wonderful presentation by Dr. Chitra.
Yeah, and we
Thank
have about eight questions again on the mandible, and the last question I think Dr. Balaji has been very keen to highlight. We'll come to that at the end of the session. Let me quickly introduce Dr. Balaji to the audience. Dr. Balaji, as much as he is popular among us, the maxillofacial colleagues, he is a fantastic caricature artist, and apart from caricature, he's contributed immensely to a lot of textbooks also. One second, I'm just getting a CV. Dr. Balaji has completed both his undergraduation and post-graduation from prestigious Tamil Nadu Government Dental College and Hospital in the year 1992 and 99 respectively. He further went on to finish his MBA in Hospital Management at Madras University. He served as an examiner in Dr. MGR Medical University, Tamil Nadu, NTI University, Andhra Pradesh, Rajiv Gandhi University, Karnataka. He has been a contributory author in the book of Illustrative Pediatric Dentistry by Dr. Chokkalingam. He has contributed illustrations and chapters in books by Professor Dr. Martin Isaac on trauma management, and a contribution in textbook of oral maxillofacial surgery by Professor Dr. Begsa is in the pipeline. With that quick and brief introduction to a wonderful person and a thorough gentleman, Dr. Balaji sir, we begin this
Thank you.
Discussion on trauma, mandible, soft tissue injuries. Quickly, we go on to the first question that has been asked. According to Zeidan-Kent criteria, why is bilateral condylar fracture without gunning splint a relative indication for open reduction until fixation of condylar fracture? Sir?
Yeah, it's no secret that the mandible condyle fractures always remains a source of controversy. To treat or not to treat, ifs and buts, all of them. But ultimately, you have to understand that the treatment method depends on it. Mainly, it is a goal to undergo. The patient's adaptation. All you have to do is to reach the goal. So the masticative system, the function, the height it has to achieve, and the disturbance of occlusion function should be restored. So all these things should be in mind to to take into the treatment. So before going into the relative, you need to understand, next slide, you need to understand what are the absolute indications for the condylar fracture. I think now you can see the absolute indication. There are four main criteria for Sidelinton absolute. So the invasion by the foreign body, obviously you have to remove it. And then the lateral extra capsular displacement obviously has to be opened and put into place. Impossibility of obtaining adequate occlusion by close reduction should be opened naturally. And displacement into the middle cranial fossa. So it has to be pulled out and put in place. So apart from this, all other things are under the things of related indications. So if you can manage like periodontal problems, loss of teeth, unilateral condylar fracture with unstable base, or you can do, or it depends on the various factors like VDO. If you are not able to restore that, you open up on one side and you as well leave the other condylar part to go to heal. So bilateral condylar fractures in initial patient without a splint is also a relative indication for a condylar fracture. You can go to the next slide. So these are all the pictures of, you can see Dr. Yogananda has contributed, given us. Look at those pictures. So there's an angle, the fracture angulation is also an important criteria. That there are various other classifications apart from this, which I'm not going to go into detail. Special strains, Wassmann's, those gives the angulation. So you open up on one side and you can leave the other for a indirect reduction. So you can see these pictures where you can see there is a splint on a denture. You can see it can be used for bringing into the occlusion. Splint type. So these are all the multiple mandible bilateral condylar fractures with the symphysis fractures being treated. Next,
yes, sir.
So I think this is you see the anterior symphysis fracture is being restored, is being anatomically reduced by using plating. Next picture, yeah. So then this an indirect fixation. Direct, it is both bilateral condyles are opened for this case. Next, you can go.
Yes, sir. This is symphysis fixation.
Anything? Yeah, symphysis fixation. And on the condyle, you can see on both the sides. One side there are two plates. Four plate and two with cap. Without cap, and two I think is used. On the other one, there is a direct fixation on both the sides. So apart from that, you bring into the occlusion. Occlusion is very important criteria. So even after fixing, you can leave this. We tend to keep arch bars for quite a period of time and use elastics to bring it into proper occlusion. Next slide. Yeah.
Yeah.
Next question is. Yeah.
Yes, sir. I'll just put the question. Yeah. And regarding the first criteria, whenever there is a loss of vertical ramal height and when you're not able to reconstitute it with the use of a denture or with the absence of teeth, that is absolute. That is a relative indication for bilateral fixation of the condylar fracture. So either you can go and do open reduction internal fixation through any of the approaches, or if there is a denture available, you can use the denture as Thomas Gunning splints and restore the vertical ramal height and reconstruct the condylar fracture. So the next question is when to intervene in cases of high condylar fracture, sir?
So the when is the two type of questions actually. It's a single word where the timing and also the indication. When, indicating when, and first we'll go to the indications. So the commonest unilateral fracture of the mandible, obviously, the subcondylar region. Well, most common bilateral fractures all occur in the condylar regions. So here also the paramount factors depend on the timing and the procedure, including for the high condylar fractures. So for this also you need the absolute indications comes into play. That is the middle cranial fossa. Then the injury to the proximal maxillary arteries. So you have to open it and you need to treat in an emergency. So before that you go, I mean, you have to need to know the classification of biocapsular fractures. Just briefly, I mean, just you can. I'm not going to go deep into that, but all these things tell you the fracture line being split either in the lateral, medial, or in the central regions. So, which warrants this immediate is what happens in C or in the M. Fracture involving the medial sections, which needs the thing. So we'll go into the indications. See, 10 al on 2010 is one of the good article to quote. So absolute indications, that is, when do you open a biocapsular fractures in which the stump of the ramus dislocates laterally out of the glenoid fossa and which cannot be reduced by closed treatment. So, and then that is an absolute indication in this direction. So then you can understand all others, like A et al. He told in 2009, absolute indication. Any type of biocapsular fractures in which the stump dislocates laterally. So that you have to understand the head, whenever the fracture occurs in the head, the stump, you have to restore it in proper occlusion. So what will happen if we do not do that is that it will lead into an ankylosis, like the Chitra madam has told in pediatric cases, but even in adults, But significantly, in Chen et al. In 2010, relative indications we have said that make the rehabilitation also more difficult and because potential TMJ problems if it is not properly managed. So next slide will show you can you come to the next slide? Yeah. This tells you about the timing. When we just addressed the when in the head, whether it is medial, central, or lateral. This when is the timing. So all those studies shows us that there are conflicting results, but there is no proper, system review in this analysis that the timing is. They say it's not as important on the outcome. The current body of evidence, definitive conclusions cannot be drawn on the timing of treatment for patient fractures. So I can go to the next slide.
Yeah. So regarding the question, when high condylar fractures are managed, as I was telling, two things are taken into consideration. Now, you need to have a very good understanding about the classification of dicapsular fractures or intracapsular high condylar fractures. And now, despite there is a raging controversy, I think, which will always be there regarding open reduction and little fixation, now we are reaching a consensus with the advent of CT imaging and improved imaging modalities. I think more and more people are trying and succeeding with successful open reduction and little fixation. So dicapsular, intracapsular fractures, unless and until they're extensively comminuted, are considered as a point for fixation. And timing is again going to be case specific, depending whether it's a pediatric patient, or adult patient, whether there is a concomitant critical injury. All those factors need to be taken into consideration to decide when a high condylar fracture is going to be managed. So these are a few other cases. We'll just quickly pass through parasymphysis along with dicapsular fracture. So a stable base is created and then conservatively managed with archwire and MMF. And this is another case, dicapsular fracture, where this has been done according
to head. You can see.
Yeah. So, derangement of occlusion, downward traction of the mandible according to the AVO principle, and then fixation.
So lag screw was placed in this.
Yes, sir.
Placed.
Yeah, that is the post-operative picture, occlusion, and the incision scar. So the next question is how to prevent post-traumatic TMJ ankylosing following intracapsular high condylar fracture. So
intracapsular condylar fractures accounts to about 65% of all the condylar fractures. So now we can understand how predominantly the risk of TM joint ankylosing is there, because most of the intracapsular high condylar fractures are the important cause for the ankylosing. So now the imaging techniques and all as Yoga said, the rigid fixation will reduce the. Nowadays we don't see much of ankylosing compared to all the earlier years, because patients also or any other center rapidly. All these methods of diagnosis are there. So always put the patient, whether the active physiotherapy is the main thing we have to understand for any condylar fractures on functional therapy. Now, on the next slide, for the sake of understanding, you just go through that classification of post-traumatic pain ankylosis. There are about 4 types of classifications based on the CT scans. Right? That is A1 is fibrous, as you all know. Then A2 is the ankylose with the bony fusion on the lateral part with the condylar stump as small as 0.5, not bigger than the condylar in the medial aspect. Then A3 is similar to A2, but the residual condylar fragment is smaller. There it is bigger than 0.5. This is smaller than 0.5 of the condylar. Type 4 is the complete fusion of the fusion of the bone. So this treatment protocol, as I think you all should just go through that. We're not going to go deep into that now. Now I think you can go to the 4th question, Yoga, if you want to complete something. Great.
So based on the Dogma classification, this is the treatment protocol for managing your type A1 to A4 ankylosis. I think the principles of ankylosis management is similar to what we conventionally do: gap arthroplasty, interpositional arthroplasty, and use a suitable material, interpose it with a suitable material to prevent re-ankylosis. So the next question is difference between rigid, semi-rigid, and non-rigid fixation.
This is actually a very interesting question, actually speaking. Now I know the R is the most raging letters and words now. So rigid, semi-rigid, or non-rigid. So the basic AO principle states that there also you can apply this RRR, the reduction. First is anatomical reduction is the one thing you have to mind. That's the first R, you would say. Then you have the R, second R, which is the restoration of blood supply or restoration or regeneration of the tissues. So then the last R is, rehabilitation of the injured part. So this 3 mnemonics you have to keep in mind for the postgraduates. R for the rigid, semi-rigid, or non-rigid. All these things are very important, R, which leads what does R. So rigid is what? What is rigid? What do you understand? What do you want by rigid? Fractured, rigid means you are bringing the anatomical part of the fracture segments as close together, as close as possible, so that there's no movement at all. So the healing is the most important step. You can see the healing, the rigid internal fixation. No callus forms at all. The healing is by the Havesian remodeling. That is the direct contact. It's called the primary healing of the bone. This primary or direct bone union requires immaculate immobilization. That is what is meaning. So that is no gap at all, actually speaking. So this is achieved only by, there you can see in that there are 2 lag screws achieve this. Not even single lag screw. By the point of period of time, these 2 lag screws, they used to generally, for the point of understanding, they were talking lag screw as a rigid fixation. But specifically, you need 2 lag screws. Then as it was talked earlier, reconstruction plate with 3 screws on ice. These are all 3 screws on each side of the fracture fragment will bring the rigid. And then, of course, the compression plates, dynamic compression plates and eccentric DCA, that types are there. So which you would have studied. So these alone bring in the rigid fixation. Then what do you mean by the non-rigid? So all other fixations which doesn't come into this modality, that is wiring. So they bring the fracture segment strong. That is not strong enough to prevent the interfragmentary motion completely. So the basic wiring, all this comes under the purview of non-rigid, any mobility. But obviously it deals by callus formation. The bone healing that occurs under the condition of mild mobility is called the secondary bone healing. So there is deposition of callus, and then it heals a little late, and also stages. So various stages it has to go through, and we have to keep in MMF for longer period of time. So this is so now we have seen rigid 1R and non-rigid NR. So what comes in between? So these are the things. So here you can see one lag screw is there also there, but single lag screw they have put it here. Then we have got the mini plates using Champy's principle, are all semi-rigid fixations, and then the locking plates, resorbable plates, 3D plates, all are semi-rigid fixations. So these things, all the PGs should have in mind. These are very important questions and point of view of exam as also for the Viva. Anything, Yoga, to add on this?
Yeah, that should be what we conventionally use is a semi-rigid form of fixation based on the Champy's principles of osteosynthesis.
Synthesis. Day in and day out, So how now we have.
Yes, sir. Please.
Now we'll finish this. Then we can load sharing. Now you have to understand what is load sharing and load bearing also. So by the definition, a load bearing, it has to bear, it has to withstand. So you understand what is bearing is. It has to be capable of withstanding the entire load applied during the functional activities of the mandible. That is, it should bear the load. So where all in the fractures it should bear? Comminuted fractures, naturally, all as multiple fragments are there. Then loss of segment, there is slight, segmental loss. So the fixation should be a good, it's good dimensions. So recon plates will bear the load of all these things. So what is load sharing? Simple linear fractures, line fractures, mandible fractures, simple ones. All these things can go in for a mini plate. So this is what the load sharing and load bearing means. Next. Anything to complete, we'll go to the.
We will just look at the case pictures.
A lot of shattered fan fascial, which has been managed by using multiple hardware. You can see how many plates, So there is a recon plate, so many fixtures, put all as much as bone as possible. So each tissue is patient's. So we have to put it back to the patient as much as possible to restore the anatomy.
The idea is being that as per the case dictates, you may have to go in for both the use of load bearing and a load sharing.
Load bearing and
load sharing. So when you have the essence is that when you have a discontinuity of the bony fragments, then probably you'll have to go for your load bearing, such as your recon plates. But as I was telling, if you have simple linear fractures or fractures that are in continuity, then you can go for your load sharing plates.
Load sharing.
So that was one case. This is another comminuted mandible fractures, fragmented. That is the reconstitution of the fragment.
Multiple plates. You can see in an interesting, go back. The plates are being put in the lower border in a different. That's a good idea to bring in the continuity.
Inferior border plating. It helps to address the splaying aspect of the
splaying aspect. So it is more or less a 3D type of fixation.
It gives better control over the splaying aspect of the fracture.
That looks nice.
So the next question: how to prevent maxillary artery injury during condylar fractures?
This is actually, it's a bit tricky. Actually, the question itself is it's not like that. It's during the management to be understood, is it not? To prevent maxillary artery injury during condylar fractures is during treatment. So obviously the maxillary artery lies very close to the medial cortex of the subcondylar and is vulnerable to injury by sharp edges or fracture fragments. So you have to be you have to understand. So this type of injuries that is sustained during blunt facial trauma. So you have to understand the anatomy. Next slide. So you have to understand the anatomy of the maxillary artery. So there are three portions, right? Which the regions divided: mandible portion, the pterygoid portion and the pterygopalatine portion. So obviously it is in relation to the anatomical structures around it. So a possible mechanism, it is underlined, the possible mechanism of injury involves a lateral force causing medial displacement of the fracture segments. So the maxillary artery is being buttressed medially by soft tissue, remains relatively immobile, and is hence lacerated by sharp edges of the fracture fragment. So direct penetration of the bone causes these type of bleeding, which has to be addressed immediately. Next slide. So we can see the management. The hemorrhage is going to be a challenge. It has to be taken up immediately. So by local means of packing, you have to make the EOT ready. Before that, you need to really assess from that the bleeding is coming, and all the pressure package, pressure, all these things should be. And then you have to look for your mind should work. You have to prepare the team, and then you have to address these issues. Yeah, next. So here you can see the CT scan, subcondylar bilateral fractures, and here they can show the CT arteriogram and their angiogram within 24 hours after surgery, confirming successful ligation. So you can see how close these structures are around the condyle. Yeah, please. So this is the algorithm of managing the maxillary artery. You can see first is the hematoma. Is it expanding or not? If it is yes, then you have to intraoperatively, you have to take it immediately. Delayed presentation is there. So direct pressure and packing. And then you have to identify it. If it's not successful, you have to open it up naturally. Okay. Next year.
So about this maxillary artery injuries, you have to remember that if it is amenable to pressure packing, which it usually not because of the caliber of the vessel, and it tends to retract. Two options you have, because it is covered by the soft tissue and the condylar fracture, it will not be able to visualize it for direct ligation. If you're not able to control it, the first option is to go for a selective external carotid artery ligation on table through a neck incision. But if it is a delayed presentation where you have the maxillary artery rupture in a case that you're about to take up, then once you identify by the presence of an expanding hematoma, and if you've identified if it's maxillary artery injury, then you go for selective angio embolization. Yeah, that would be the treatment of choice for
usually the venous can be pressured and it can be stopped, but artery is always an artery. You have to improve.
Yeah, so that is about your maxillary artery injuries and condylar fractures. The next question: what are the treatment options for avulsive lip injuries?
Yeah, now you have to understand this contour of the lip first before, and restoring the contour is always going to be a challenge. Like because of usually the Romelian bottom, that is a very critical junction, Romelian bottom junction. So this is so according to the defects, next. So the upper lip defect usually, 1/4 of the lip you can address by direct closure. For the lower lip, it is about 1/3 of the lip. Primary closure you can attempt. So your goal is to bring the continuity of the romanar border, and then obviously the muscle of orbicularis oris. Then the oral competence should be, that is, your goal is to restore the competence. Then the maximum sensation has to be preserved. Adequate aperture size. So all these things you should have in mind to restore the defect. So there are various flaps which are there. Apart from the primary closure, I told 1/3 of the defect can be addressed by primary closure. The rest all, there are the Abbe lip switch flap, then Eslander flap is there. Then you got the Bernard-Webster flap for the lower lip construction, Willis flap. Then you got the Karapanzik flap is also there. So these are all the various then lip defects. The avulsive is trauma, obviously. There is burns, due to burns. Then after the tumor or the infection disease also this lip and lip defect is there. So this is the challenge part, as I told you, is the commissure of the lip on the vermilion border, which you have to restore. Next. So here you have got a good, interesting picture. So, yeah.
This was a case of
I think
trauma.
a bite in an eye.
Trauma. Bike fall with extensive avulsion injury of the upper lip, with loss of anterior nasal spine projection, collapse of the nasal projection, extensive dental-alveolar injury, vestibular injury, and he had a huge lacerated tongue. Because of the tongue, and part of it was going for early cyanosis. But here, this was primary switching done in the casualty. This was in the OT, where the wounds were reconstituted. This is his immediate on-table picture after closure. Only thing, this, because of the loss of anterior nasal spine, this projection was going to be an issue. And because it was a midline injury, we did not go for a submental intubation, also was difficult. So we had to go through a nasal intubation. And this is his 2 months. This patient was operated in January. This was somewhere in March. Yes, a minor defects, I think, will go for.
Which can be recorrected.
Yeah, revision. Revision is planned for. I think otherwise he will come around fine. So that was lip, and this is his tongue that is healed. And this is the lip injury. And this is another case. Extensive mid-face injury, soft tissue injury, and this is his late post-operative. So as I was telling regarding lip injuries, avulsive lip injuries, if it is amenable for primary closure, that is, if the defect is less than 1/3, 3 things that you have to remember is reconstitution of the vermilion border of the white roll. The white roll has to match the white roll for continuity, the dry vermilion to dry vermilion, wet vermilion to the wet vermilion. That is how we put back the lip together if you're able to address it primarily. If you have about 1/3 to 2/3 of the defect, I think you can still mobilize and advance the tissues and get it back into position and still follow the same principle. But with more than 2/3 defect, where you have avulsive tissue loss, concomitant tissue loss, a composite defect, then you're talking in terms of locoregional flap or distant flaps. And most commonly, as we're talking, was the Abbe flap. You can lip switch. If it is a commissure defect, as you see in a lot of trauma cases, you go for Abbe Estlander flap. If it is a broad lower defect, then you go for a Bernard Webster flap, or a Karapandasic flap, or a Gillies fan flap. Or if it is a bilateral, if you want to advance it, you can take inferiorly based bilateral nasolabial flap and reconstitute the lower lip. You have a huge choice of flap, and mostly they are axial pattern. They have a dominant vessel, a labial artery or a facial artery based flaps can be moved and reconstituted for managing lip defects. So that brings us to the end of discussion on avulsive lip injuries. The next question that we have, sir, is management of parotid duct injury.
Yeah. So the parotid duct, the face can carry multiple complications due to the anatomy. Its region takes the facial now, then the duct is there. So how do you address the parotid? Basically, you have to understand the classification first. I mean, Van Sickles classification first. I'm not put it here. It's based on the site of injury. I mean, the level of, it's based on the relationship to the masseter. So the proximal to the masseter, or over the masseter, or anterior to the masseter. So that classify where the injury occurs. So usually the over the site is called as the site B injury. Site B injury on the masseter. So then you got the site A and then the site C. So the initial incision itself is based on the level of suspicion of the injury. So then the next slide here, proximal distal. So how do you address that? So yeah, you can go to the next slide. I think by seeing the picture, yeah, the most important step is identification of the branches of the facial. As I said, a lot of structures have to be preserved before you address the parotid duct. So then it's identified. Then all these tubes are elastic tubes. Then the catheter, small that they used for cath catheter, angiocath thing was also used for to connect the. Once you identify the parotid duct, then you have to cannulate the ends. If you're able to identify both the cut ends. So I think you can see this picture there. So as I told you, the site B is on the top of the muscle, where it most commonly injures. So the red is seen as this, that is the stent, and the green portion is the cut end of the transected ducts. So you have to bring the ducts together, insert a stent inside, and then you have to do the microvascular sutures. Micro sutures. Usually 8 and 10 nylon is used around to keep it patent, and then you can remove the stent later on after 2 weeks. So this is how you treat a facial, parotid duct injury. So based on that, the primary, if you are able to do that, it's good. But if you are not, if it is too close on the parotid duct, you can leave it out. You have to suture it onto the mucosa if you are able to identify. And then if it is very at the proximal, that is, the proximal end. But doing it with this type of stent is going to be difficult, and it is a microvascular surgery at the end of it. Now next, you can see here the site A. I told you this is the site A is on the proximal aspect. So if you can identify that bit of the cut section, it is okay. Otherwise, if you're not able to identify it, you can leave the distal end of the parotid duct, and you can take that proximal cut end and suture it patent and suture it on the buccal mucosa. So this is designed to prevent post-operative. If the surgeon is able to repair the duct over the stent is trimmed at the level of the oral papilla and sewn to the oral mucosa around the second molar. Is where actually the stent index opens. So it's going to be a meticulous surgery, but this is the treatment. Anything, Yoga?
Yeah. This parotid duct injury is most commonly to injuries on the cheek, concomitant to trauma, sharp penetrating injuries that transect the duct at the 3 sites that Sir told. Usually, if it is at site C, if it is close to the papilla or the duct opening into the oral cavity, that usually you just cannulate and you just allow it to heal. But if it is in the mid portion, that is site B, over the masseter, if the laceration, you identify the long buccal nerve, which in between the 2 divisions of the long buccal is where you find at the anteroposterior border of the masseter. That is where the duct makes a bend, and that is where it usually gets transected. There is a sharp penetrating injury on the buccal mucosa. You identify it, then you cannulate it from intraorally, identify the stent, and then do the procedure as serve as detailing out. If it is close, that is site A, if it is at the site of the emergence from the substance of the gland itself, and then that has a different technique of management because the duct tends to retract inwards. Nonetheless, this parotid duct injury with any sharp injury or laceration over the cheek, buccal mucosa, through and through incision, through and through cut injuries, especially over the cheek, like those with jackknifing injuries where you have glass cutting across the soft tissues, or any sharp instruments, sickle injuries or assaults with sharp objects, you will have to always keep in mind this parotid duct injury, the possibility of parotid duct injury, and that there, if not addressed or identified and addressed early on, you can always end up having a parotid fistula or a psilocele. Apart from all these microvascular techniques, the advent of psiloendoscopy also has been a game changer in managing parotid duct injuries, but all this warrants a complete discussion in a different setting. So this is a gist of how do you go about managing your parotid duct injury. So I think we'll go to the last question of the session. It was This was the,
So it's the most-
oddball out of the whole session. Management of dog bite in the
Dog bite.
facial region. So we'll just go into this, sir. This was
This is the prophylax algorithm. I think rabies, I think it's a dog bite, with long limb. I mean, the limbs are usually, it doesn't, facial-maxillary, unless otherwise children, or if it is a Great Dane, really a high dog which catches the face. Children's are most commonly affected by the dog bite. So the local wound management is basically it is the same actually, except that the foreign materials has to be removed. Copious irrigation is really a must. Debridement of devitalized tissues. Then you have to the wound irrigation is really a must, because the saliva from the various organisms or the microorganisms in the dog's saliva mixes with the skin or whatever it is, and it penetrates deep into that. So irrigation. Then when it is safe, then you can start doing the repair. If it is a small, that is the category is the bite, So depending on that, you can do the primary closure, and then potentially the injuries, actually disfiguring injuries, can really wait, balancing the aesthetics and the infection, and you have to balance it. And then it is really, I told you, it's a common injury in the children. It catches the nose, mostly then around the cheeks. Then some cases of fracture also have been reported on that. So these staphylococcus, streptococcus, tetanus, all these things can get into through the skin into the deeper planes. So the rabies, you have to watch the dog. If it is known, 10 days is the period, as you know. Then the rabies protocol is started, and then that is it for the dog bite. End of the section.
Yeah,
nothing much I could gather apart from this. If anything,
this dog bites mostly the puncture wounds. They're like puncture wounds rather than an avulsive type that we usually see with trauma. These are puncture wounds where a chunk of tissue is usually
removed,
damaged or removed.
One incidence of unknown animal was reported in our hospital in RGGH, where he was sleeping outside in a forest area, and some animal gored into his face, entire face, and the orbit was lost. So the entire thing was reconstructed. We have the pictures, but I couldn't get it through here.
Usually those kind of mauling injuries, these animals.
Yeah.
Extensive damage to the facial apparatus. Yeah, I think that brings us to the conclusion of this was the article, Damage of Facial Tissues, that Sir had shared for your reading. Damage of facial soft tissues as a result of being bitten by a dog. Very descriptive topic. Yeah, and I think that brings us to the end of your session on mandible soft tissue injuries. So, as always, as observed, and most of the sessions on mandible, the hero ends up always being condyle. A lot of question on condyle. I hope you have the entire understanding. Open reduction is gaining momentum with good surgical skill, with good armamentarium, with good diagnostic capabilities now. Open reduction internal fixation should emerge as a front runner where indicated, but there is always the flip side being where you don't need to do, you stop, you avoid doing it, and conservative methods can still give you optimal results. And for the rest of the discussion that we were having regarding this parotid duct injuries, I think everything has been adequately answered. So I think we'll conclude. I'll thank both Dr. Chitra ma'am and Dr. Balaji sir for their time and fantastic presentation of the questions that were posed in this Ask Your Mentor session. Thank you so much, TNA OMSI Tamil Nadu Puducherry chapter, Dr. Jimson sir, Dr. Kalpa for fantastically coordinating, and for Ilavenil for orchestrating the whole show. Thank you so much. I think I will pass the baton on to ma'am, who will conclude. Sashikala ma'am.
Thank you, sir.
Yeah.
With this, we come to the end of the session. On behalf of Tamil Nadu AOMSI, we would like to extend our heartfelt gratitude to the mentors and moderators for their valuable contribution and sharing their knowledge. Now the participants are requested to stay connected to fill in the Google feedback form that is posted in the chat box. Filling up this is mandatory for your certificates. Please fill up within 10 minutes. Thank you, Dr. Chitra ma'am, Dr. Balaji sir, Dr. Yogananda sir, for the excellent and very informative session. Thank you all.
Thank you, ma'am.
Thank you.
Thank you very much.
Thank you so
Thank you.
much.
Thank you. Thank you.